I really welcome you to Japan in a Venous store. Congratulations on Vein Week.
Vein Week. Vein Week. Vein Week.
From Jakarta, Indonesia, Vein Week.
Hello from Indonesia.
Vein Week.
Vein Week.
Vein Week.
Vein Week.
Vein Week.
Vein Week.
Vein Week. Vein Week.
Vein Week.
Vein
Week. Vein Week.
Vein Week.
This is Dishma from Fukuoka, Japan with our staff.
Vein
Vein Week. Vein Week.
Vein Week.
Vein Week.
Vein Week.
Vein Week. Vein Week. Vein Week.
Venous Week.
Vein Week.
Vein Week.
Vein Week.
お時間となりましたので、続きましてメインウィーク企画ジャパン・インドネシアジョイントセッションを始めます。座長は日本静脈学会副会長小川智弘先生、山本静脈瘤クリニック山本隆先生です。座長の先生、よろしくお願いいたします。
Hi, good morning. Today we have 3 guests from Indonesia, and we have very good time last night. And we get friends. I'd like to welcome you all, but the sessions, other than this, the other sessions are all held in Japanese. I'm sorry, but this is the only session you can talk in English. So please say everything you want. Okay? Yeah. And we are behind the schedule. And
Good morning, I'm Ogawa, and I serve you with Dr. Yamamoto as the chairman of this session. First speaker is Dr. Kusagawa, and the title is the large scale questionnaire survey on adverse event of the cyanide pathway closure in Japan. Current result and the progress with the discussion. Please welcome.
Thank you, Dr. Ogawa, Dr. Yamamoto. I would like to congratulate Dr. Imai on hosting the Indonesia-Japan joint session. No COI. An analysis of the FDA complication database reported the possibility of high incidence of serious adverse events in CAC treatment in October 2023. Given the concerning report, Japanese physicians sought for guidance regarding the safety of continuing CAC treatment. This prompted an urgent national survey to determine the incidence and outcome of CSC AEs in Japan. Plan 1, urgent survey on serious AEs showed their absolute numbers. Plan 2, urgent survey for major AEs showed their incidences. Here is a summary of Plan 1 and 2. First, background is shown. A total of 24,209 cases from 338 facilities were enrolled, accounting for 73% of all CSC cases performed in Japan during the same period. Most CSCs were performed under local anesthesia, and in over 30% of them, treatment for side branch varices were also treated simultaneously. As shown in the slide, the incidence of serious AEs after CSC was not significantly higher than other treatment. Localized phlebitis and systemic hypersensitivity were characterized as specific complication after CSC. Plan 3 involves detailed analysis of each AE and is currently underway, starting with phlebitis containing HSR. But there are a lot of problems. The first problem is that there are too many cases. Secondly, the term phlebitis is ambiguous and encompasses many different things. Thirdly, there is no established treatment for this viral phlebitis. Phlebitis is a general term for inflammation occurring around veins. Reported causes include type 4 hypersensitivity, foreign body inflammation, and thrombophlebitis. One or more of them may be involved in the pathogenesis, but it is difficult to distinguish them clinically. Possible treatments are presented based on the cause. However, it is difficult to determine the cause from the symptoms, and treatment strategy vary from doctor to doctor. Therefore, we decided to limit our study to cases treated with oral or intravenous steroids, as we expected that the number of severe cases would be high. We are currently investigating the background of patients, surgeons, and materials, and analyzing the actual treatment effects and duration of symptoms. From here, I will present my first case of refractory phlebitis after CSC in my 615th case. This case is believed to have been caused by a severe foreign body reaction. A 76-year-old woman with no history of allergies and or autoimmune disease. She underwent CSC of bilateral GSPs. She presented with two ulcers measuring 4 to 5 centimeters in diameter on the left lower half. On the 7th day, she had painful redness, induration, and swelling only along the entire CA injection site on the right side only. The condition of her right leg worsened slightly over the first 1 to 2 weeks, but she had no systemic symptoms. It showed a tendency to improve during the 4th to 10th week, but fistula gradually appeared on 2 places on the thigh and 3 places on the calf. The condition showed a tendency for further improvement during the 10th to 12th weeks, with numerous cylindrical CA being sequentially discharged from each fistula. Ultrasound examination revealed inflammatory thickening around the right GSP only, while the left GSP showed a normal progression. This case must be a typical one of severe polybody inflammation. However, the contributing factors in either the patient, surgeon, or materials were unclear. Therefore, the cause of the disease remains a complete mystery. In conclusion, serious adverse events with CAC were not more common than with other treatment. Phlebitis is relatively common post-operative complication, but serious cases were rare. The cause of its onset is still unclear and is a topic for further investigation. Thank you for attention.
Thank you very much, Dr. Kusagawa. And he also talked about the complications of the cyanide closure, especially we can use that only venous closure. So the main topics of the adverse event of the CAC is the phlebitis. So do you have in the floor, on the floor, there are there any question or opinion? Oh, so please.
Good morning, Sensei.
Good morning.
I'm Dr. Adi from Indonesia. So it's a very good presentation, and I see it's a very serious effort in overcoming that national problem regarding the hypersensitivity. I do have some comments and maybe questions. I see the hypersensitivity rate is only 0.27%. I think it's really the same with the worldwide report, around 0.3%. And secondly, should autoimmune patient be actually excluded from receiving CAC treatment? And secondly, for local phlebitis, for instance, or allergy after CAC treatment, do you ever inject steroid as a tumescent around the blood vessel? I've tried with some of my patients with triamcinolone and lidocaine mix, and some patients actually were relieved from the symptoms. But I've never overcome systemic heavy symptoms. Thank you very much.
Thank you, Adi.
Can you answer the question about
Yes. Phlebitis contains many components, in part hypersensitivity, but other one polybody reaction. So very confusing. And steroid injection, I cannot do that. But in the United States, Dr. Fukai said she injects subcutaneous steroid injection for the local phlebitis. but temporary. Temporary.
Also, in this survey, do you get information about autoimmune disease patients, especially who had phlebitis or hypersensitivity?
Very difficult, but it had general symptoms, maybe HSR. But local phlebitis is very difficult to distinguish them.
Thank you very much. Please.
Thank you very much for the good presentation. My name is Shinji Tomita from Gifu. I have one question. And although the complication is 1 out of about 600, it's very, very rare percentage. But after you experience that one cases, you change some strategy between the CAC and the laser operation, the ratio between treatment.
My private
Yes,
opinion. So I choose the treatment method by the form of the
varus vein.
refracting state. That's the first decision. The first decision.
After getting your experience important complication, do you explain only one but very, very serious complication to the patient before operation? You explained about
yes,
the other
of course. But the incidence, I told them the incidence, incidence is low,
Right. Yeah.
so they can understand that.
Okay. Thank you very much.
Are there any questions on the floor? And I have one question about I have one question about your survey. And you can also find out that many cases of that phlebitis that included that hypersensitivity. So, but in my current practice, and mostly the patient have not had any complication about that after the CAC, included that phlebitis. So I think that currently many Japanese physicians also that learn that how to do that cyanide closure for the varicose vein. And do you think are there any learning curve for this procedure?
I don't know that, but because this case, my case is a 650 case, so I cannot explain it.
Thank you very much. Are there any questions on the floor? Thank you very much, Dr. Sarawa. We'll move on to the next speaker, Radi Sensei, and the presentation title is Acute Fluoride Primitive Deep Vein Thrombosis, How to Deal with it. Very welcome from Indonesia.
Good morning. I'm Radi from Indonesia. I come from Jambi province. This time I will present my presentation about acute lower extremity deep vein thrombosis and how to deal with it. Disclosure, I have no financial conflict of interest. And then the first one for acute venous thromboembolism or VTE, including two of these, and the first one is deep vein thrombosis, and the second one is pulmonary embolism. And the incidence is about 1900,000 annually in US, and then the men are more than women. The risk factor is including age, immobilization, travel, history of VTE, malignancy, surgery, and trauma, pregnancy, oral contraceptive, and hormonal therapy. For the natural history of the recanalization, after acute DVT event, the recanalization will occur. Observed in 44% patient at 7 days, so we can use ultrasound to see the recanalization, and 100% occur at 90 days after the acute event. Complete thrombus resolution will occur 9 months at the 56% of patient, and recanalization may continue for more than a year after the acute event. For the 30% patient will have recurrent DVT in 10 years. So it's for the predictor of the old age, obesity, malignancy, and extremity paralysis. This is for the diagnostic tool for the DVT. For the gold standard is venography. The sensitivity and specificity is 100%. For the rural area, we can use ultrasound and color Doppler because the sensitivity and specificity is near from the gold standard. This is for the ultrasound and color Doppler. The image can show us the thrombus is non-compressible ultrasound and there is no color Doppler flow. For the surgical and interventional treatment, we can separate into 4 therapy. For the first one is operative venous thrombectomy. The second one is thrombolytic therapy, divided into 3 types, and the third one is endovascular aspiration thrombectomy, and the last one is endovascular angioplasty and stenting. For the early thrombus removal, there is a reasonable body of evidence supporting a strategy of thrombus removal, especially in patients with iliofemoral deep vein thrombosis. When strategy of thrombus removal is successful, venous patency is restored and valve function can be preserved. Quality of life is improved and the risk of recurrence is reduced. This is the image for operative venous thrombectomy. The venous thrombectomy for iliofemoral venous thrombosis provide effective short and long-term outcome with relatively few complications and have indicated that the early and long-term patency rate of the iliofemoral venous segment is about 18% versus 30% in patients with anticoagulant alone. This is for the contraindication to thrombolytic therapy in DVT. The absolute contraindication including active internal bleeding or DIC, recent neurovascular event below than 3 months, the absolute contraindication to anticoagulant. and there is relative contraindication. The recent major event, CPR, neurologic disorder, intracranial lesion, uncontrolled hypertension, severe thrombocytopenia, severe dyspnea, renal failure, pregnancy, severe hepatic dysfunction, bacterial endocarditis, and diabetic hemorrhage retinopathy. This for the patient selection criteria for endosvenous stenting. When to consider the venous stenting? The first one is for acute DVT or iliofemoral DVT, and then symptom present below than 40 days and candidate for thrombolysis. Evidence of residual thrombus or obstruction following thrombolysis. Chronic DVT including established post-thrombotic syndrome with significant moderate to severe symptom using validated clinical score, example for Villalta score and shape classification, and iliofemoral stenosis or obstruction confirmed by imaging. This is the imaging of angioplasty and stenting. The first image can show up pre-angioplasty and stenting. The second one is when the stent is deployed, and the final angioplasty and stenting can show up the result is good. And endoveinous stenting has emerged as the method of choice to treat iliofemoral venous outflow obstruction. It used in the patient established post-thrombotic syndrome after previous deep vein thrombosis to reduce symptom of chronic pain and swelling of the patient and ulcer healing also in severe case. This is the review article published at 2024. Catheter direct CDT or catheter direct thrombolysis demonstrated promising result in enhancing venous patency and reducing post-thrombotic syndrome, with careful patient selection being crucial. Pharmacomechanical and pharmacomechanical thrombectomy device offer immediate and long-term benefit, emphasizing individualized patient care. Venous stenting serves as a crucial adjunctive therapy, particularly in patient in residual venous obstruction. Through further research is needed in optional patient and long-term outcome. This is the review of Annal of Vascular Surgery for July 2019. In CDT or CDT decrease in incidence of PTS when treating iliofemoral DVT, but pharmacomechanical thrombolysis does not. CDT also reduces the incidence of recurrent VTE, but leads to more bleeding than other therapy. Thank you. Arigatou gozaimasu.
Thank you very much, Dr. Wadi. I also talk about the acute degree thrombosis for treatment in Indonesia, and that also give the review of this treatment. And are there any questions from the floor? Please, Dr. Hai Sensei.
Thank you for your great presentation. I'm Hayashi from National Cerebral and Cardiovascular Center. And so there are various treatment strategies, for example, medication or surgical and endovascular treatment. So my question is, in Indonesia, how do you select treatment strategy in Indonesia?
So can you
So which case you perform surgery or endovascular treatment or only medication?
in Indonesia we prefer first for the medication first. We use anticoagulant first, and then after the APTT is we get until 1.5 until 2.5. We use operation example as venous stenting or angioplasty.
And I have one more question. In Japan, recently we can use a new thrombectomy device. And so, how about in Indonesia? What devices are you using?
And for thrombectomy device, we already use pharmacomechanical thrombectomy device like JET-I or angiojet in many cases. Maybe for the usually most usually in Jakarta, because Jakarta is a big city. For me, in rural area, we can do open thrombectomy.
Thank you very much.
Are there any questions? Dr. Radi, I have a question about that, also strategy of the acute deep vein thrombosis. At the new first line is that anticoagulation, I understand, but sometimes that we met that severe deep vein cases like that pre-emergent cellular Lawrence, like this patient have the kind of swelling of the very with the pain and also have the cyanosis. So in this case, what type of the treatment do you use at the first? Anticoagulation or the treatment, surgery or the venous treatment?
Okay, thank you, Sensei. For the Blackmasia cerulidolens, we usually use medication first, and then we do surgical treatment like fasciotomy and open thrombectomy for the venous.
Do you have any kind of development of the surgical treatment for the DVT? Actually, currently thrombectomy for the DVT is obsolete in many European countries, also in Japan. And still, you also have some development of the surgical treatment for the DVT. Like you also after that also you underwent thrombectomy. Then you always, not always, but when you find out that stenosis was obstruction of the iliac, then iliac vein, and then you soon underwent the intravenous treatment, like the venous stenting was so.
For the venous stenting, we asked for the recommendation of European Society for Vascular Surgery is not recommended for the acute DVT. So maybe for the chronic DVT we can use the iliac stenting.
Okay. Any question from the floor? Thank you very much. Thank you very much. And then we will go to the next speaker, Dr. Hindra, and the title is the iliac venous stenting for the refractory venous ulcer, stenting versus ablation. Very interesting content. Please welcome.
Thank you, everyone. Thank you, the moderators. And it's a great honor and pleasure to be here. And like Dr. Imai already said at the beginning, actually, I don't know what he said in Japanese, but yeah, we have a very good time here, starting with Tokyo, Kyoto, Osaka, and this beautiful NARA. And my topic today is about the iliac venous lesion for reflux with the venous ulcers. What should we do? Should we do the venous stenting first, the iliac stenting first, or should we do the superficial venous ablation, or should we do both at the same time? And this is the topic of debates in many different conferences. I have no conflict of interest for making this presentation. Before we move on to papers and discussing it, we have to differentiate between the deep and the superficial. When you have a patient with a deep, when you have a patient with a CVI, with the pathology of the deep venous obstruction, I don't think you have the patient with heart swelling. And this is the classical presentation. They may have MTS, metronome syndrome. They may have the severe leg swelling, and they may have the classical codifications where the leg was so swollen when they're walking, and they have pain and appendix cogitation, right? And in contrast with the superficial, the right pictures, they may not have swelling. They may sometimes have swelling in the localized region, especially in the ankle region, especially in the night or the afternoon after long standing and sitting positions. But when they get up in the morning, they have no swelling. So they were a different pathology, and as you know, the blood return to the heart from the leg is 90% done by the deep venous system. And if you have a patient with a deep venous obstruction, you're gonna have a severe swelling. And superficial venous system only takes care of about 10%, and yeah, that's you're not gonna have swelling. Let's jump into the papers and what happens when you see the articles. This is the article from George and France, published in the European Society 2014. It shows that the deep venous interventions effective in healing the ulcerations. And also there's a lot of papers in the Asia shows the same results. They positively leads to a faster healing. And and this is another paper from the Colby Ruiz and friends. It is said that iliac venous stenting leads to a higher healing rate and ulcer-free time for the first year. Okay, yeah, this one. And this is the papers from Saadi and friends. This is a small sample study. And again, they're treating the patient with a challenging venous ulceration. and they're treating, but they're not healing, and they're searching for the iliac lesion, and what they found out that 50% of the patient with the ulceration had a stenotic iliac lesions, and after stenting it, 58% of stenting patient was healed. And this is some other papers from the Journal of Vascular Surgery 2013. It is said that the venous ulcer healing can be augmented by the iliac venous stenting. And this is again a small sample study, but they showed a very similar result that this is published in the Journal of Surgery 2016, and they treat a very challenging venous ulceration, and they treat it but they don't healing, and 60% of the interrogations the iliac vein was stenosis, and after stenting the healing time is much shorter. And this is another paper from the Joe Pantoja and France. It is published in the Journal of Surgery 2021, and it is said that the recalcitrant venous ulcers with the central venous obstruction after deep venous stenting the result in a high rate of healing. And this is a little bit more possible. It is said that when you combine, when you do the superficial venous ablations and the early iliac stent placement for the complex suprachoroidal venous disease published in GVSS 2016, there was symptomatic relief and a well-maintained ulcer healing rate. And this is important for some other people because there's a selection bias, because are you selecting your patient with only the deep venous reflux, or are you selecting the patient with only have the superficial venous reflux, or you have concomitant disease? Because I think some of these papers, some of these resources, at least to have some selection bias. And this is the paper from the Peter Lawrence to 2019. So he asked the same question. So he gathered 11 centers in the US and 800 patients, and basically he bordered with the same question. So what should we do here? Should we do iliac venous stenting first, or should we do the superficial venous ablation first, or should we do the both at the same time? And what they found out that the superficial venous reflux as well as the deep venous stenosis both contribute to healing the venous ulceration. So what is the very telling about this study is all of 800 patients, only 130, that's less than 50% of the patients had an iliac lesion. So I think the message here is clear. Selecting your patient is very important because not everyone with the venous ulceration had an iliac occlusion, iliac obstruction. So what is the basic idea of the venous ulceration? The basic idea is one thing, the venous hypertension. You have to reduce the venous hypertension that are going to reduce by either you putting the stent on the iliac or treating the superficial venous reflux. But for me, treating the superficial venous reflux is more important because it's closer to its bed. It's closer to its pathology. And why is treating the superficial venous reflux is more important? Because we have two level 1 evidence starting with the ASCA study. It shows that the surgical corrections of superficial venous reflux reduce 12 months of the ulcer recurrence, and most of the patients with a simple chronic ulceration will benefit from the addition of the simple venous surgery. And this is the second one of the level 1 evidence with the EFRA trial. It shows the same. It is said that the venous ablations of the superficial venous reflux result in the faster healing of the ulceration that positively leads to a faster healing rate and a faster healing time. So I think iliac venous stenting is beneficial, might be beneficial, but I think again substituting the superficial venous reflux is important in these cases. And what is the conclusion about the controversies? The first one is the iliac venous stenting is a very great procedure, but I think it's the adjunctive procedure, adjunctive therapy for selected patients along with the superficial venous treatment. And the second one is the superficial venous treatment, in my opinion, is the main therapy of the healing the ulcerations. And the third one is, don't forget about the whole treatment of the venous ulceration and the wound care. Because if you don't wound care, no matter what you put the step, if you put the best standard word or you put the best technique in putting the stent in the iliac, if you did a great ablation, if you don't wound care, you never do a patient. Thank you.
Thank you very much. Very impressive but informative presentation about the treatment, the management of the venous ulcer for the chronic venous ulcer disease. Are there any questions? Please.
Thank you very much for the presentation. I'm Yushi Ishimoto from the Municipal Hospital. Very great presentation about the very challenging strategy for the superficial venous treatment and the deep vein treatment. How do you decide which is first for superficial vein treatment or deep vein stenting?
Thank you for the question. For me, I think we have to select the patient because selecting the patient is very important. When the patient comes with only the superficial reflux with the venous ulceration, of course we only do the superficial venous ablation. But the patient with, if the patient comes with the swelling, we have to check the deep venous system, especially in the supraumbilical region, the iliac region. So if they have occlusion or stenosis or obstruction, is more than 50%. I think the first point therapy is, of course, we do the superficial venous ablation because it's near to this pathology, right? Near the ankle. And the distance between the iliac and the ankle region, probably the ankle region that usually the venous ulcerations comes, right? It's very, very far because there's collateral around the way. So basically, I'm suggesting the superficial venous ablation as the first therapy. But if there's another more than 50% of the stenosis in the iliac region, you can do the putting the stent in the iliac.
Thank you.
Are there any questions from floor? Okay. I have a little bit question about the venous ulcer management and treatment. In our society, especially the Japanese society, Prevolge recommended that the first line of the venous treatment is compression therapy. Using the stocking and the bandage. But then we also have a discussion about the compression therapy for the compliance, patient compliance. Patient compliance is very important for improvement venous ulcer. So, do you have any recommendation to improve the patient compliance?
Yeah. Thank you for the questions. I think I agree with that. Patient compliance is very important because not every patient will comply to wear the stocking all day. So I'm suggesting the patient can wear the stocking maybe in the working hours from morning to the afternoon, and they can get off the stocking in the night. So it's more possible and it's more comfortable for the patients, and something like that. It's difficult to be honest.
Thank you very much. Are there any questions from the floor? Thank you very much. Very informative.
Thank you.
I will move on to the next speaker.
The next one is efficacy and safety of different types of thermal ablation in Indonesia, an early prospective study. by Audi. And I heard that his follower is 70,000, right? Please go.
Okay, thank you very much. So yeah, I'm going to talk about the efficacy and safety of different types of thermal ablation in Indonesia. It's an early prospective study, so it's not complete yet, and we still have a lot of things to fix, but I would like to share some of the early data that we've had. Okay, there's none to disclaim. Okay, as a background, we all know that lower limb varicose vein affect up to 1/3 of our population, although not everyone has to undergo treatment. But at some point, this prevalence will increase along with increased age. So it will, of course, significantly impact the quality of life and morbidity. And as we know from the NICE guideline, endothermal ablation comes first in comparison with other types of treatments. And currently we have 3 modalities in Indonesia. With RFA, we use closure fast. I'm sure all of you are quite familiar with this device. And for endovenous laser ablation, we have been using BioLitech mainly, and there are at least 5 other brands available. Now for this new device, endovenous microwave ablation, it's called ECHO. It's actually the second attempt to enter Indonesian market in 2023, right? So it has been around before, but nobody really used it because at that time the evidence base was not really strong enough, and we were very hesitant to use it on the patient. So I think among all of us, only one ever tried it. Now, a question appeared then afterwards. Is endovenous microwave ablation better, or at least on par with EVLA and RFA? Now, here's the basic principle. So with EVLA or laser, we call the device fiber, but with microwave, because it emits microwave frequency, we call it antenna, right? Now, with thermal coagulation effect of microwave's energy, the ablation catheter directly acts on the vein cavity and vascular wall. So it achieves instant generation of high temperature to coagulate tissues. Okay? But some papers have shown also that it works through apoptotic pathway. So sometimes when we monitor using ultrasound, it's not really constricted immediately, but after a few minutes, it will contract. Okay, so this is the development of microwave ablation. I don't know if you can read it, but the first use of microwave was actually in Japan in the 1970s as Professor Katsuyoshi Tabuse. So the basic principle of microwave ablation is actually to treat solid tumors, right? Now that it has been established that it uses thermal energy, so it may be usable also for varicose veins. So the Chinese companies developed this device further, and it has become the machine that we've been using. The procedures is more or less the same like any other thermal ablation. So it is thermal, so it requires tumescent anesthesia. We use normal tumescent formula, but sometimes since the patient is under general anesthesia or total intravenous, normal saline is also usable. So as for the catheter tip, we put 3 centimeters below the saphenofemoral junction. One of the papers that was released in China, it compared the efficacy of EMA and RFA. So actually, both have very good technical success and similar operative time. However, the direct cost in China is lower for endovenous microwave ablation, but the hospitalization is longer for microwave. 48 hours post-operative pain. There's more pain for microwave ablation. And this is one of the problems that we've been facing with Indonesian patients also. There are more hyperpigmentation with endovenous microwave ablation. The recurrence rate is similar and the cause of complications are similar. So we wanted to compare the efficacy and safety of microwave, laser, and radiofrequency ablation for lower limb varicose vein. Now here's basic principle of endovenous microwave ablation. So it is actually similar to radiofrequency. However, with radiofrequency, you pull back around 7 centimeters at a time. With microwave, you pull back 1 centimeter at a time. And for the first 5 centimeters, you use 2 cycles per centimeters. Right? So you sort of burn 10 times for the first 5 centimeters. If there's a local aneurysmal dilatation of the main trunk of the great saphenous vein, we perform re-ablation second time on that very spot. Okay, it's a prospective consecutive cohort with adult patient with lower limb varicose vein undergoing thermal ablation from January to December 2024, and it's a multi-center cohort study. The inclusion criteria with symptomatic lower limb varicose vein C2 to C6 with specifically GSV incompetence. Okay. And the exclusion criteria is just regular contraindication to anesthesia and surgery. This is what we collected pre-operatively and post-operatively. Okay, this is my patient. So we conducted on 142 legs or 71 patients, right? 45 underwent IFLA and 22 underwent IMA. More or less they're comparable with diameter, but we did not actually record which one has the diameter for IFLA and IMA. Okay. As for the fast scale, we can see IFLA has slightly higher fast scale, but it's only, I mean, there's not really any difference between fast 1 and 2, right? I mean, like both are treatable using oral painkiller. Right? However, the ecchymosis we found more on the laser patients, and the hyperpigmentation we found more on the microwave patient. These are the results from Fatmawati General Hospitals. As we can see, there are a lot of more complications regarding hematoma, infection, burn, etc. But there's another reason for this. Most of the surgeries were performed by surgical vascular surgery trainees, not by the attending. And they actually have a lot of patients. Sometimes they have 70 outpatient clinic in a day, and they have to treat the inpatient. And also, they have a lot of surgeries. As a discussion, so microwave characteristic is it enhances thermal efficiency, rapid heating, and moderate thermal penetration. So basically, since it's thermal, it's the same, and it can achieve a successful GSV closure. And there's another study by Chow in 2023. It has a comparable GSV closure between endovenous microwave ablation and radiofrequency. Okay, here are my conclusions and limitations. So, for the time being, microwave ablation appears to be usable for Indonesian population with similar outcomes to IFLA and RFA. However, the data are inhomogeneous, so we still have a lot of things to fix, like the inclusion criteria and also post-operative measurement and what we should record. And all the patients underwent sedation. So unlike European countries, they like to perform ablation under local anesthesia only. So it's just an office procedure. So it's difficult to monitor whether the patient is actually experiencing pain at the moment we perform the ablation or not. Early Indonesian data suggests that microwave is comparable to laser and radiofrequency ablation. And since Fatmawati and my hospital are two different hospitals, one is private and one is government-funded hospital, there's a discrepancy between the coverage. Right? So in some area, like where Dr. Radi is working, endovenous thermal ablation is not reimbursed. So the surgeon can only perform stripping. And with private patients, some patients have already asked Dr. Google a lot. So sometimes they have a type of treatment in mind and that they want to ask to the doctor. So, doctor, what do you think about microwave? I read it's very good, it's very new. Is it suitable for me? So it's difficult for the doctor sometimes to convince, let's not use this and use that instead, right? And with private patients, we call it it's hit and run. Some people are actually happy with the treatment, so they only we can only monitor the progress through, for instance, like WhatsApp or video call, teleconferencing medicine. And some of the patients are from outside Jakarta, so when they come to Jakarta for treatment, they go back the next day, and sometimes we never hear from the patients again. Now, for government hospital patients, the follow-up is quite difficult because you need a referral letter from the GP, right? So, and it takes time, at least 2 to 3 days before the patient can finally see the doctor. Okay. With government hospital patients, the treatment is done by different vascular surgery trainee every month because we rotate training, so we can't really have a standardized treatment because, of course, everyone has their own consideration and touch regarding surgery. And we urge that a randomized control trial with large sample size comparing the efficacy of this treatment is required to confirm current findings. Okay, this is one of the example of the hyperpigmentation. As we can see from this area. Okay. This is one of the worst hyperpigmentation. For the rest, it's not this clear, but it's there. It's more than the laser patients. Okay, thank you very much.
Thank you for introducing us the microwave ablation. And can I have a comment from discussant AEG Shima?
Mantap picture. Thank you for informative presentation about the EMA. So in Japan, we cannot use the EMA under the medical insurance. So what is the difference of the EMA and venous laser ablation? In my opinion, these two modalities can controllable by depend on operator, the ablation power and pullback speed. So what is the big point to use EMA for pigmentation or another adverse effect?
Okay, so yeah, basically like you said, it's operator dependent, right? With laser, there are many more parameters that we can control, like the pullback speed and also the LEEV, the power, right? With EMA, it's actually, it's like RFA, right? So if you, with laser, you have to have a personalized touch, right? Like how to pull it, right? With EMA, it's quite easy actually. You just put it there, set the power, and then pull it back one by one. That's it. I think for young vascular surgeons, if they just start doing private practice, for instance, endovenous microwave ablation is quite safe. Right? So with laser, of course, if you put too much power, then there will be side effects like burning and also nerve damage. But with EMA, it's quite safe and quite easy to do. It takes a bit longer than laser, but not that long.
Okay. So I have one more question. So you use EMA 2 cycles near the junction. And another point, for example, do you use the EMA for the lower extremities, G3? and the small saphenous vein?
Yes, I do actually. So normally I puncture near the ankle because most Indonesian patients, they don't come at early stage, right? They come when the GSV is already dilated until near the ankle. So we have to treat the lower GSV also. So yeah, I puncture close to the medial malleolus, close to the ankle. And also I do microwave ablation on the short saphenous vein.
Thank you.
Thank you very much.
Any other questions from the floor? Okay, thank you, Dr. Ali.
Thank you very much.
For the presentation. Again, we are behind the schedule. Next, novel insights into body figure of patients in shunt acrylate closure of various veins. Speaker, Dice K. Akagi.
Thank you for, ladies and gentlemen, thank you for Chairman and President Dr. Mai. Let's go to the lunch, do quick. Okay, let's start. No, nothing to disclose to have a financial interest. So, you know, acrylic closure, CAC, is one of the less invasive treatment to trunk of varicose veins. Physicians usually select treatment methods as they like. Previous reports are shown in this slide. Recanalization rate may vary by the team. Various reports are in this. This is a procedure of CAC with Venous treatment. First, this is the first preparation glue filling to the catheter and puncture when inserting a sheath and placement of the tip of the catheter to the junction, and then Doppler scanning it to determine embolization site position. So we start the compression and glue drop here, the vein. I think essence of this CAC treatment is compression is important. To avoid and secure the adhesion of the vein, compression is very important. Doppler scanning, this is a picture of Doppler scanning. This is the center of the vein, hyperechoic lesion with acoustic shadow. This is a very good occlusion of the saphenous vein. This is another view of the Doppler scanning. This is saphenous femoral junction, and then here the patent of the patent area or patent veins after the treatment of adhesion. This is a so-called stump length. This is, I think this is important for the treatment of the veins. I'll show you our results of our report. This is some old data. I previously worked at Tokyo, and around 6 or 7, around 9 months, 2020, and 47 cases and 6 cases with CAC treatment. My treatment policies are shown in this slide. In CAC treatment, I didn't perform concomitant procedures such as sclerotherapy, aneurysmectomy, and prophylaxation because CACs are very, very minimally invasive surgery, so I didn't perform another surgery. But, however, compression therapy is performed for all patients at least 1 month. Legs with edema is 63 and skin changing 64, and then others 65 and 6 were used to, for these patients. We use stockings longer term. Patient demographics are shown in this slide. 47 cases and 65 livings. 20 cases are treated bilaterally. Age and height, weight, and BMI are shown in this slide. This is a slide with C classification symptoms. Only C2 without skin change or some other severe change is only half of the patients, 46% C2, but C4 and C5, C6, 35%. This is a number of the treatment saphenous veins. One saphenous vein that treated is half, 55%, and then two saphenous veins that treatment also 49%. This is the types of the saphenous veins are shown in this slide. Two DSV 67%, 2/3, and the small saphenous vein 1/3. No accessory saphenous vein, none. So this is a slide of diameter of saphenous vein. Bigger saphenous vein is not so good for CSC treatment. But, this is a diameter, average diameter in GSV is 7.3 millimeter proximal to the junction, around the junction. But the largest part of the vein, varicose vein, is 8.8 millimeters. But of course, smaller saphenous vein smaller diameter in GSV comparing to GSV. This is a small short-term preliminary study. 1 month, all of the cases are followed up, but 3 months, 6 months, less follow-up patients are reduced. Symptoms after 1 month, at 1 month after embolization, all the patients have symptoms before varicose veins. But varices, 8.5% of patients we can identify that varicose veins, still the small varicose veins. Treatment result at 1 month as shown. Frontal occlusion, all of the patients succeeded in the 4 embolization. Decanalization is none. Patency from the junction, so-called stoop length, is 18 millimeters in average. But the distribution varied from 0 to 72 millimeters. In 19% of the patients, cases, these are occlusion from the junction identified. But I don't know the meaning of the difference, importance, but many, 24% of cases, remnant peripheral reflex distal to the puncture site is identified. Complications as follows. Phlebitis is talked in this session, but in this case series, only 2.8% are shown. Others are shown in this slide. Body figure by target veins are shown in this slide. In GSP treatment, high and BMI is not, between GSP treatment and SSP treatment, BMI is not different. To consider patterns of recurrence, I think one of the important difference and recurrent pattern is remnant branches around the junctions, especially in saphenofemoral junctions. Several branches, superficial pudendal vein or superficial pudendal vein or some other accessory saphenous vein, origin of the recurrence. So I think the origin of these branches should be occluded, should be embolized in this treatment. So zero stamp is preferable, I think. So I investigated the samplings from the junction. At 1 month data, almost more than 90%, less than 45 millimeters of the stem length. But 6 leads shown more longer, over 65 millimeters. Stem length is this is a slide comparing to GSB and SSB in stem length and occlusion rate and total occlusion rate. It is different from the GSB is longer than SSB. But I think total occlusion rate is higher in SSB. But longer stump cases as shown observed only in GSB groups. I checked these cases. So age is not so different, over 45 millimeters, longer stump length patients, but height is small, and BMI is much higher, significantly bigger than short stump length patients. Vein diameter, treatment length, and amount of fluid is not significantly different. This is spread again to assess of venous sinus closure. It is important to adhere the vein. Compression is important. Why? We use the compression with probe for probe of duplex. So, of course, saphenous vein is compressed. Only we cannot compress vein with not only vein but also subcutaneous tissue. So you imagine this as how compression. This is the Pythagoras theorem. You want to compress this direction and to compress the saphenous vein. We have to, the surgeons should have to compress also subcutaneous tissue. Thick fat layer may block the proper compressions around the junction and long stem length around shown in this slide. So, to select the patient with proper body figure would be important in CAC. Less thin fat layer might be important for CAC treatment. The limitation is shown in this slide. Small number, single center, short period of follow-up, one surgeon's experience. All cases are done by one surgeon. In conclusion, compression is important and protrusion to avoid protrusion with DVT. Body figure may be a factor of considered treatment method in varicose vein surgery. More investigation and longer follow-up should be done in the future. Thank you for attention.
Thank you, Dr. Kagi. Can I have a comment from Ladi? Please make it short.
Thank you for the time. I will ask you some questions. For the first, for CAC treatment, is there any consideration the contraindication for patient who will underwent CAC procedure? And the second one, how to deal with CAC complications such as allergy after treatment? Thank you.
Thank you. First thing, I'd like to make sure you have asked the question. You mean the first patient who should be avoided CAC treatment. Is that correct?
Yes.
Yes. Absolutely avoid patients with allergies for glue and some allergic potential should be avoided. But for other than patients, other than these patients, other than factors of them, we can perform for everyone. And second question is frequency of allergies and so on like that.
Yes.
In this session, many people, other presentators discuss phlebitis allergic directions. In my experience, about 3%, and Professor Ogawa also said that not so critical, clinically severe. So we can wait and prescribe medication for the symptoms. It can be treatable.
Thank you.
Thank you.
Thank you. The doctors from Indonesia, please stand up. We are so pleased, satisfied with sharing experience with you. So it's a great honor. So please give them a big applause. Thank you for cooperation.